And my name is Professor Rebecca Fitzgerald. I'm a trustee for the charity, and I'm also a Professor of Cancer Prevention and a gastroenterologist at the University of Cambridge. We've held webinars and in-person meetings for patients with Barrett's and esophageal cancer for a number of years now. And we've always found it very useful, both as presenters, I should say, as well as patients and participants, because we get a lot of useful feedback and information from you. So thank you very much for joining. The format of this evening is going to be 4 short talks covering different aspects from surgery through to gastroenterology and Barrett's surveillance, as well as thinking about dietary tips to reduce heartburn, and also what the pathologist looks for in your biopsies. So those talks will each be about 15-20 minutes. They're quite different in terms of the topic, so I think we'll take questions after each one. Probably best because there are 42 on this webinar, which is fantastic. If you pop any questions you've got in the chat as we go along, and then I will try and go to those in the Q&A and make sure I cover them all. Some of them I may group together if they're similar sorts of questions, and we'll try and get through as much as we can during the evening. And we've got up to 2 hours for this set of talks and Q&A. So thank you again for coming. I'm going to now introduce our first speaker, Mr. Rob O'Neill. Great pleasure to welcome Rob, who's a consultant upper GI surgeon at Addenbrooke's Hospital here in Cambridge. So Rob came to us from Scotland. So he completed a PhD at the University of Edinburgh, and he's got a particular interest in minimally invasive esophageal cancer surgery that he's developed during his time both here in Cambridge and in Utrecht. And he leads our interventional surgical service for us here at Addenbrooke's, and he also joins me and my research team doing research at the Early Cancer Institute. So, Rob, the question that you have to address is a bit of a controversial one. Do we still need a surgeon for Barrett's, or can we do it all down the endoscope? Over to you. Thank you very much.
Thanks, Rebecca. Hopefully everyone can hear me. Give me a wave, anybody that can. Oh, wonderful. Thank you. So sorry, I'm slightly informal today because I've been covering emergencies today, and as some of you may be aware, there has been activity in the hospital of late related to strikes. So anyway, on to something interesting. And the question I was asked to answer was, do we still need a surgeon for Barrett's? So I don't have any disclosures other than, as Rebecca suggested, I am a surgeon and I work in the Cambridge Esophageal Gastric Centre. Those of you from this part of the world may recognise this aerial view of the Addenbrooke's campus. I don't know if you can see my pointer. I'll make it red dot, hopefully that becomes visible. So that's the AstraZeneca building. The Addenbrooke's Hospital is over here in various different components, with Papworth off to the right. And in fact, our ward that hopefully none of you will ever be on is across here, operating theatres over this side. And the research institutes are just sort of down in that area there. So I wasn't going to really say that much about Barrett's, because I imagine many of you in the audience are very well educated about exactly what Barrett's is. But the question I was asked was, do we still need a surgeon for Barrett's? Well, the first question I might ask is, did we ever need a surgeon for Barrett's? In fact, does anybody with Barrett's ever need any treatment at all? Strictly speaking, the answer is no, because of course Barrett's is not something that worries us. It's the transition to cancer that worries us, and through the step of dysplasia somewhere in the middle. Now, how do you find out you've got Barrett's? Well, most people that have a diagnosis of Barrett's have had an endoscopy for some reason. Usually they have symptoms, and this is the first point where you might consider the skills and tools that a surgeon can offer. So most people have had an endoscopy, been diagnosed with Barrett's, might have reflux symptoms. And we now have very effective medical treatments for reflux. However, it's still worth remembering that for people with refractory symptoms, or who don't tolerate antacid treatment very well, fundoplication may be a very effective treatment for those reflux symptoms. Fundoplication is the surgical procedure where, demonstrated on the picture on the right hand side, you effectively tighten up the loosened valve around the gastroesophageal junction to form an anti-reflux barrier. Now, what's the long-term efficacy of fundoplication? Well, now through laparoscopic techniques, we're able to do this minimally invasively. And we now have 20-year outcomes from randomized control trials done at the end of the 90s, start of the 2000s, which demonstrate that at 20 years, if you've had laparoscopic fundoplication, patients feel that they've had a good or excellent outcome in 85 to 90% of cases. It is worth also noting that many people will not need PPI medication in the early period after anti-reflux surgery, but over time those numbers do start to creep up. So at 20 years, around 30% of people are still taking PPI. When you drill down into that, not all of those patients are taking that for reflux, but there is still some patients who are on medication at that time period. So this is not a panacea for everyone with reflux, and certainly it is only successful in selected cases, but we do have successful outcomes. So that's to treat the symptoms that you might have if you have Barrett's. But of course, we're really thinking about what about the endpoints of Barrett's that hopefully none of you ever reach, of dysplasia and cancer. Red hot controversy alert. Can fundoplication prevent the progression from Barrett's to cancer? Now, this is a question that's been kicking around in the literature for around 20 to 30 years. I cannot tell you definitively yes or no at this point. I can't recommend fundoplication as a preventative strategy to develop in the progression from Barrett's to dysplasia or dysplasia to cancer. And NICE doesn't recommend it either. But there are some literature suggesting in selected groups there may be regression of dysplasia. Massive caveats associated with those studies, but it is an area of active research about whether or not we can prevent this progression by preventing the reflux. So at this point, I wouldn't say you should have a fundoplication to prevent progression, but that is a question that has been posed. So did we ever need a surgeon for Barrett's? Well, this is borrowed from a colleague of mine, Richard Hardwick, who gave a presentation similar to this around 20 years ago. So this was the state of Barrett's surveillance in around the year 2000. And it's quite similar to the current state of surveillance with some caveats. I would just draw your eyes to this point here. So the idea is that if you have no dysplasia in your Barrett's, you continue on a surveillance program. Well, the current recommendations are quite similar. And this may be elaborated a bit more with more up-to-date data in the other talks this evening. If you develop low-grade dysplasia, well, we check if that's still the case following antacid treatment. And if it's no dysplasia, you go back to surveillance every 3 to 5 years. If you've still got low-grade dysplasia, we might consider some treatment at that point now. But the important thing is if you've got high-grade dysplasia, we were previously quite concerned that you might be hiding a cancer within that dysplastic field. And so the recommendation at that point was, if you were fit, to consider an esophagectomy. If you're unfit for an esophagectomy, well, then we tried to ablate you at that point. And the same was true of cancer. So that's what we used to do. So you did need the use of a surgeon if you had Barrett's around 20 years ago. So this was an example of an esophagectomy. Apologies for anyone that's tucking into their dinner and doesn't fancy the gory pictures. So this is an example of an esophagectomy specimen. This is the squamous lined esophagus. This is the stomach. And within this area, quite a short Barrett's segment. It's been sliced through actually, an area of an early esophageal cancer. So an esophagectomy was the treatment of choice to take out all the diseased area, including the lymph nodes. Fortunately, in the last 20 years, there have been endoscopic treatment developments, predominantly in the Far East initially, but those techniques have spread across the world. And I'll categorize them broadly into two. One is an endoscopic mucosal resection, or EMR, and another is an endoscopic submucosal dissection, or an ESD. The EMR, the central principle of this is, for a small lesion, that might, for example, fit into the end circular diameter of an endoscope, you can fit a cap onto the end of the endoscope, suck that area of mucosa into the cap, and then ligate the base of that, much like you might snare off a polyp elsewhere in the GI tract. And then by resecting this area of mucosa that's been lifted into the cap, you end up with a defect in the mucosa and retrieve that area that has been resected. So you sort of nibble off a segment up to around 12 millimeters in diameter. So this is quite a useful technique if you just want to sample, take a big biopsy effectively, an area of the mucosa. The limitations of this technique, well, it's difficult really to gauge how deep you're going and to do a very a careful dissection for potentially along that deeper plane there. And also you're limited by the size of the lesion because you can't fit anything particularly bigger than the size of the end of the cap. For slightly bigger areas, more advanced techniques involved using cutting tools down the endoscopic working channel to lift in this plane that runs along the muscle here and eventually resect off larger areas of the mucosa. And after painstaking dissection with the endoscope, you can resect an area of mucosa that's fairly large, that's pinned out here on this cork board. And if I flick your eyes back to that surgical resection specimen, you might imagine that, for example, this area here corresponds perhaps to this endoscopic resection sample here. So it seems that we can now resect some of these mucosal lesions, at least endoscopically. What do I mean by mucosal lesions? Well, for those of you that aren't aware, the thing that we worry about in Barrett's is progression to dysplasia and eventually to cancer. And this is part of the staging that we use, T-staging, for esophageal adenocarcinoma. And I'll just talk you through this diagram. So this is if you've sliced the esophagus lengthways. This is the outer line of the esophagus. This is the muscle layers. This is the submucosa, and there's that mucosal layer. And according to the depth of invasion of the cancer, we give a different T stage from T1A, which is intramucosal, T1B, which is submucosal, T2 and onwards. T2 and onwards, the tumor has already invaded into the muscle wall. So I'm afraid the surgeon is still required for cancers at that point to remove that. Where the debate point comes is in the T1A and T1B area. And we worry in the T1B cancers that potentially lymph nodes are involved because the lymphatics are just within the submucosal area and maybe in contact with the cancer. And if we look at the risk of lymph node metastasis, according to T stage, we can see that it's really very low, according to the published historical data for intramucosal cancers. But as cancers progress into the submucosa, the risk goes up, and then on to the T2 onward stage, where the risk is about 30 to 50%. And if the cancer's in the lymph nodes, it clearly makes very little sense just to resect the primary tumor here and leave cancer behind. So the decision point really is around what to do with the T1A and T1B cancers, whether they should be treated with endoscopic treatment or be offered surgery. Well, those are the two options. What's the outcome of those options? We know that the surgeon can take all the lymph nodes out and potentially tell you what final stage you have, whereas endoscopically you might leave those lymph nodes behind. But if we were to do an esophagectomy, which is one of the biggest operations we can offer anyone, there is some risk associated with that. This is the most recent data on the risk of mortality after esophagectomy. So this is England and Wales data. Each of these little blue points represents a centre in England and Wales, according to the number of resections they do in this period, 2018 to 2021. I've highlighted Cambridge, where I work. That's our centre there. So we did around about 180 resections in this time period. We're very proud that through a combination of improvements in perioperative care and surgical care that we're able to offer a very low perioperative mortality rate, with a 90-day mortality rate around 2%. But in fact, that's true across the board in England and Wales, with a mean rate of around 3%. But that means 3% of patients having surgery don't survive beyond 90 days. So it's clearly a massive undertaking. It's not just about mortality, though. There is morbidity, there is risk of complications after this sort of surgery. So these are two contemporary studies I've pulled out. One from the Dutch National Cancer Audit, where they've looked at the risk of complications in around 1,600 patients having esophagectomy in the time period, I think 2015 to 2018 or thereabouts. And they found that although the mortality rate was similar to the England and Wales data, very low, 65% of patients had postoperative complications, reflecting the magnitude of this surgery. This is another study looking from the ESO Data Collaborative, which is across the world. 6,000 patients included in this study, fairly contemporary data. Again, 60% of patients having postoperative complications. So clearly there is a risk to going ahead with surgery. So back to our surveillance algorithm. Is there still a place for surgery? Well, I wouldn't say for high-grade dysplasia anymore, because for that, there is no risk of lymph node metastasis that we're aware of, and endoscopic techniques are suitable. What about patients who have cancer, esophageal adenocarcinoma, the T1A and T1B lesions? Well, what we need to know is how effective is endoscopic resectional techniques. And I've just included some data here on endoscopic submucosal dissection. So that's the slightly larger lesions. This is the largest study I could find on this. So it's a meta-analysis of 11 published trials, 500 patients, 524 lesions resected for Barrett's neoplasia. The median lesion size was 27 millimeters. So thinking back to why they didn't do EMR, bigger lesions needed complete dissection with an ESD. Pride classification, most of those were fairly short segments of Barrett's, and 379 out of those 500 resections had a diagnosis of cancer. So there was some dysplasia within this cohort. But overall, the risk of complications is low. Bleeding at less than 2%, perforation at less than 2%, stricture, having resected most of that mucosa, you might imagine there's a bit of an inflammatory response associated with that, and that can cause a stricture which can affect swallowing afterwards in around 12%. This is through very high volume centers who are experienced in this technique. They can achieve a 75% R0 resection rate, which effectively means the margins, both the deep margin and the lateral margins, are clear of any tumor. And 65% of those resections were deemed curative. That is, they took off a lesion that they thought was an early lesion and completely resected it, and the patients didn't need any other subsequent treatment. And in a fairly short follow-up period, the recurrence rate of lesions was fairly low. So that's the global perspective, but most of the people dialing into this call are probably from the UK. So what about UK data? Well, I've pulled out this from a recent presentation from one of the largest centres doing ESDs. So this is their series of 244 ESDs at a single centre for Barrett's neoplasia. Again, similar to that meta-analysis data. 30 millimeter lesions, fairly short segments of Barrett's, low rate of complications, even lower in fact than that meta-analysis suggested, around 1% for both bleeding and perforation, and a stricture rate around about 10% ballpark. 93 of the patients went on to have ablation after their ESD, so it's not the only treatment they had, but it was another endoscopic treatment. 25 patients, so 10% of the cohort, had another endoscopic resection, so they needed further treatments. When they looked at their subgroup of patients who had a pre-treatment diagnosis of cancer, so T1A or T1B cancer, again, 74% R0 resections, most of them early lesions. 13% of their patients then proceeded on to esophagectomy for whatever reason. So it's not necessarily a question of ESD or esophagectomy. Sometimes it's ESD followed by esophagectomy, so the surgeon's still involved in that treatment. So what is the best treatment for T1A or T1B esophageal adenocarcinoma? So this is the exact topic of a study called the Congress study, which is being led by my colleague, surgeon Phil Butcher in Portsmouth. It's a retrospective cohort study recruiting centres across England and Wales. In fact, they've extended it to become an international study, looking at patients with either T1A, N0 or T1B, N0 esophageal or gastric cancer. So it does extend slightly on to the non-Barrett's population. But for the UK, in fact, most of these are esophageal adenocarcinomas associated with Barrett's, contemporaneous for the last 7 years, treated with either endoscopy or surgery. And they're going to report on the outcomes, which will be short-term clinical outcomes and pathological data. So this will tell you definitively what is the risk of lymph node metastasis in contemporary cohorts of these patients. And I'm very pleased to highlight that the results of this are going to be presented as the prize oral presentation at AUGIS next week on Thursday, for anyone that wants to dial in to find out the result. Just to highlight, these are the UK centres that have contributed data. We were narrowly, well, not narrowly, actually Leeds were quite far ahead of us in terms of numbers, but we did come up in silver position there in terms of number of patients recruited into that study. So I'll summarise now. Patients with Barrett's often have reflux, and so in selected cases, a reminder to everyone, clinicians and patients, that surgery may have a role in symptom control. I cannot recommend fundoplication as a preventative measure at this point. I think it's pretty clear the data suggests that as well, that low-grade or high-grade dysplasia within Barrett's can be successfully treated with endoscopic therapy, and therefore surgery doesn't have a role here. We can offer endoscopic therapy to patients with early esophageal adenocarcinoma, that's the T1A or early T1B, safely, it appears, in UK practice now, with a low rate of complications, and as a curative treatment, 2/3 of patients. However, 15 to 20% of patients undergoing endoscopic resection still have surgery as part of their treatment. And more evidence of the safety, contemporary safety of these techniques and the pathological outcomes is being generated within the Congress study, which we should have the early results of next week. The most important thing is, though, that patients with Barrett's neoplasia don't follow a defined algorithm all the time, and it's very important that patients are managed within a multidisciplinary team. So I'm going to include my last slide, which is to thank members of the rest of our multidisciplinary team, fellow surgeons, dietitians, upper GI specialist nurses, anaesthetists, physios, and all the rest whose photos aren't on here, to say that we're the team providing treatment in the Cambridge Esophageal Gastric Centre, and I'll thank you for your attention. Thanks.
Thank you very much, Rob, for that very jam-packed talk with a lot of data and information. So just a reminder, you're very welcome to ask any questions. Just pop them into the chat. I've got one for you, Rob. Is the Icaro device worth trying? I don't know if you're familiar with this.
I'm afraid I'm not. Is that an endoscopic clip device? Or
no, I mean, I was going to ask you about those, but this device, I have to say, I had to look it up too. It's a thing you put in your mouth, and it's supposed to train your diaphragmatic muscles by doing exercises through a little sort of mouth tube. I don't know quite how to describe it. It's supposed to help snoring, sleep, and reflux.
Well, it's not something I've come across. There are a group of patients who have air swallowing as a sort of unconscious thing, and they can get quite bad reflux because your stomach fills with gas and then it generates pressure and then you get bad acid reflux. So we used to be able to recommend speech and language therapy techniques, which is exactly diaphragmatic education, to try and control air swallowing, as well as some other things like avoiding fizzy drinks and sipping with a straw and so on, to avoid this, and that might be the partly behind the mechanism of action there. But clearly it's a zero risk intervention, so if it works for you, then absolutely. Yeah,
thank you. And you raised the endoscopic treatments for reflux. Obviously there's the medication which most people are on who've got any indigestion, heartburn, Barrett's. things like the proton pump inhibitors in particular, omeprazole, lansoprazole, pantoprazole, esomeprazole. And then you talked about the surgery treatment with the wrap or fundoplication, usually done keyhole. But what about the endoscopic treatments of either clipping or sewing or implanting something? There are a number of different techniques that have been used over the years. What would you say about those?
So the rationale behind that is to sort of try and recreate a valve at the bottom of the esophagus, and the concept being that there has been loss of the valve. In my experience, most patients, there are a few patients who have absolutely no hiatus hernia but have bad reflux. And in that very small proportion of patients that I see anyway, an endoscopic technique may be of benefit. Most patients I see have a degree of hiatus hernia, and the difficulty with an endoscopic technique is you don't really deal with the hiatus hernia, so you create effectively a stricture point, and then you haven't really dealt with the underlying issues. So the long-term data are probably where it will become clear what benefit there is, and it may be the case that patients who've had previous endoscopic treatments become much harder to salvage with surgery later on, and so that's something else worth bearing in mind. There are some others that haven't come up on here, such as a magnetic sphincter device, for example, that's proving popular because for the very same reason you do less dissection. The theory is less surgery, quicker operation, but you're leaving an artificial object beside the esophagus, and history has taught us that can cause problems down the line. So definitely worth discussing with a clinician if that's something that interests you.
Yeah, and the National Institute of Clinical Excellence, NICE, has good review data on these various different therapies, and they've reviewed the safety and efficacy. So that's always useful information. So we've got a comment here from Mariana Bellu. She's one of our clinical specialist nurses, and she was just talking, making a comment about the UKRO device and saying that she does have a patient that's been using it and it costs about £100. I don't know, Mariana, if you have got feedback from that patient or if you wanted to add any comments.
Can you hear me?
Yes.
Thank you. So I have reviewed the patient since they started using it. At the time, she had only been using it for a month, and she didn't have much improvement at the time. But from her own research, she had said that it takes approximately 6 to 9 months to see benefit. And I had to look it up because I wasn't aware of this device. And yeah, it's for dysphagia and acid reflux patients, obviously without known cause. So yeah, once I have more feedback, I can certainly let you know.
Thank you very much. Thank you, Mariana. So, and then an observation from Nick Oxbury, and I completely agree with this sentiment, because when I was first treating patients with dysplasia in Barrett's, high-grade dysplasia, I had no option but to send them for an operation. And now, as you point out, Nick, and you had high-grade dysplasia, you could have it treated endoscopically and didn't have to go through the very big operation of an esophagectomy. So things have moved on tremendously, and now it's far fewer patients that we have to send for surgery. But as you said, Rob, there are patients where the disease is going a little bit deeper into the submucosa, where the risks, favour doing an operation, the risk-benefit ratio, to try and make sure that we've really given the best possible outcome and reduce the risk of the cancer coming back. So thank you, Nick, for sharing your experience. Liz Chipchase, who's on our HCUK committee, and she's also had, she may want to tell us her own story, but your question, Liz, is what factors affect the rate at which esophageal cancer develops? So can you predict how long it takes to move from dysplasia to stage 1 and stage 1 to stage 4? Rob, it's a tricky question, that. It's a very good question.
It is a very good question, and I suppose I might punt that straight back to you, Rebecca. But I mean, to my knowledge at this point, there is nothing we can say other than for example, if we had 2 time points where we had some information, for example, a CT or endoscopic features that might allow us in real time in that patient to predict that. But we don't have good data to say, if you start with a T1A cancer, we can wait this period of time before we know it will definitely be, a T2 or more advanced. But we do sadly know that esophageal cancer is quite an aggressive cancer among the spectrum of the cancers, and so often we don't wait to find that information out, and so we only, we get on and treat people as soon as we know. In terms of the rate of progression of dysplasia, well, this is something that, Rebecca, you have been researching for, so I won't embarrass you by saying how long.
Yeah. So, I mean, I think one point to say is that not all esophageal cancers are likely to progress at the same rate, because when we look at the molecular features, they can be quite variable, and we think that there are some cancers that are much more aggressive than others. In terms of the dysplasia going to cancer, I added that on to Liz's question. She didn't actually ask about that, but we know there are factors that put people at higher risk, which include increasing age, male sex, obesity, smoking, longer segment of Barrett. So those are all factors that affect how often we follow people up. Alan's been waiting. Alan, we're very patiently. Would you like to ask your question?
It's not really a question. It's just going back to the mundane, the Icaro device. I've read that it has been approved by NICE and is available on the NHS.
Oh, thank you very much.
Good luck with persuading your GP, I believe.
Okay. And actually, Fiona LeBroy, who's works with Heartburn Cancer UK, says that she has a couple of patients that has been in touch with on the HCUK online support group who have found the Icaro device useful. So I think glad someone brought it up, and Rob and I will go and find out some more information. So brilliant. I think that's all we have time for on the surgery. Rob, thank you very much indeed for a fantastic talk. And I'm going to introduce Andreas now. So Andreas Hadjinicolaou is a gastroenterologist, and he obtained his medical degree from Cambridge. He then went on to Oxford to get his PhD. He's been to all the best places because he's also had experience at Stanford and London, and I'm pleased to say he's now back in Cambridge with us. He's a clinical lecturer in gastroenterology, which means that he spends about half his time doing clinical practice and half his time doing research with myself and Dr. Di Pietro in our research group. So Andreas, you're going to tell us what is Barrett's and how do we monitor it? Thank you very much.
Hi, good evening, everyone. Can I just check that you can hear me, first of all?
Yes, perfect.
Yeah, fantastic. Thank you, Rebecca. I'm just gonna see if I can share my presentation. Can you see my screen?
Yes, we can.
Yes, yes.
I've got, sorry, Andreas, I've got your slides up. I know you're probably in a place with bad signal, so I'm happy to keep it that way if you want.
Yeah, that sounds great. Yeah, we can do that. Fantastic. And can you see my cursor on the slide, please?
Yes, we can.
Nope, that's mine. Okay.
That's online.
Okay. Andreas, do you want to try and share yours again, see if that works?
Adam, I think in the interest of time, you share it, and Andreas, I'm sure if you could describe, you don't need to use your pointer, if that's okay.
Fine. I just want to make sure you can hear me. Apologies if you can't.
No, we can. It's all perfect.
Okay, fantastic. So thank you, Rebecca, for the introduction. As you said, I'm a clinical lecturer in gastroenterology at the University of Cambridge and Addenbrooke's Hospital, and my talk has been devised in such a way to mainly address non-healthcare professionals, and I'm going to try and take you through an overview of what Barrett's is, how we diagnose it, and how we monitor it. So if we change the slide, please. Okay, so we've already had a lovely talk, but you might have some questions about what exactly is Barrett's actually, and what is dysplasia, and what is a hiatus hernia. We'll try and answer all of those questions. So Barrett's esophagus is the term we use to describe a condition where the normal cells lining the esophagus, commonly known as gullet or food pipe, change and become abnormal. The esophagus itself is a muscular tube that connects the mouth to the stomach, for those that are not aware. And in fact, the condition, Barrett's, occurs at the very bottom of the gullet, at the point where the esophagus meets the stomach, which is known as the gastroesophageal junction. At that point, altered cells begin replacing the normal ones and spread upwards along the esophagus. For reasons that we still don't fully understand, these new abnormal cells in the esophageal lining are very typical of what we normally find in the intestines when observed under the microscope, rather than the esophagus. And this process is known in medical terms as intestinal metaplasia. This stems from the Greek word metaplasia, which means a change of tissue from one type to another. So if we can change slide, please. So this is on the left how a normal esophagus would look on endoscopy, and on the right-hand side what Barrett's would look like. So to the naked eye, these abnormal cells cause the lining of the esophagus to change from a lovely pale skin-like color to a salmon pink color. And this is in fact how we diagnose the condition when we perform an endoscopy. Change slide, please. So it's important to diagnose because it is a potentially precancerous condition associated with an increased risk of developing a specific type of esophageal cancer called adenocarcinoma, which Rob has already alluded to and talked about briefly. Barrett's affects approximately 1% of the population, although I should mention that this is potentially an underestimate because of how often there is lack of symptoms. And really, I don't think anyone is quite sure how common it is. Change of slide, please. So what are the causes of Barrett's esophagus? The main cause is gastroesophageal reflux, whereby acid from the stomach inappropriately enters the esophagus, where it irritates the otherwise healthy gullet lining. Essentially, there is an imbalance between the anti-reflux mechanisms at the gastroesophageal junction, the valve that Rob had mentioned, and the acid-generated mechanisms that create a chronic, recurrent chemical damage of the bottom of the esophagus. Most patients with Barrett's esophagus have background acid reflux, and this happens as the valve between the esophagus and the stomach gradually fails to work properly. Unlike the stomach that can handle the high acid environment, the esophagus is unable to do that. In many cases, patients also have a hiatus hernia, which Rob again mentioned, and mentioned potential surgical options for that. But what exactly is a hiatus hernia? It's when the top of the stomach comes through the diaphragm which is the muscle separating the chest cavity from the abdominal cavity, and it pushes through the diaphragm into the chest. And in this scenario, the anti-reflux barrier at the lower esophageal sphincter is impaired, allowing more acid produced in the stomach to enter the esophagus and irritate the lining. So all in all, Barrett seems to be the result of long-standing chemical damage due to inappropriate exposure to acid from the stomach. Change of slide, please. So who is at risk of Barrett's esophagus? So individuals at risk would include those with a long-standing gastroesophageal reflux disease, for example, between 5 and 10 years. And our research globally suggests that approximately 5 to 15% of patients with gastroesophageal reflux can develop Barrett's esophagus. Other people at risk are those with a hiatus hernia, as mentioned, for very similar reasons. Those who are obese or overweight, particularly those with abdominal obesity, where the majority of the adipose tissue is concentrated in the tummy. Those of older age, more commonly more than 50 years old. Males are at higher risk. So we see patients with Barrett's, our male to female ratio is 2 to 1. Being of Caucasian background, being white, again, puts you at higher risk. And we know that white men have a 3-fold increased risk compared to the average population. Smoking, whether that's current smoking or in the past, and a family history of having Barrett's or esophageal adenocarcinoma. Next slide, please. So in terms of symptoms, it's crucial to know, first of all, that about 40% of patients might experience no symptoms at all and still have Barrett's. This is because Barrett's esophagus itself, it's simply an active response to acid reflux. And once developed, it might cause no symptoms such as pain, as there is limited inflammation. However, 60% of patients will have symptoms, and these are typical of acid reflux, which is in fact the condition associated with Barrett's esophagus. And the cardinal symptom, as you can see at the top left, is heartburn. Heartburn that worsens or is exacerbated at night when an individual lies flat and perhaps wakes patients up at night is a particularly strong indicator for Barrett's. Other symptoms will include chest pain, upper abdominal pain, recurrent belching, and nausea with fluid or fluid regurgitation. Less often, Barrett's can cause symptoms that cannot be otherwise explained, such as coughing with sore throat and voice hoarseness, but also a metallic or sour taste in the mouth. And occasionally, patients with Barrett's might experience difficulty in swallowing food, a symptom that should in fact trigger alarm bells, as it is often concerning of more sinister pathology, i.e. progression to cancer, and requires more urgent investigation. Next slide, please. So how do we decide who and when to screen for Barrett's esophagus? So generally, these would depend on your physician's assessment, but based on our clinical guidelines, we generally suggest that we should screen when someone has regular, and by regular I mean at least weekly, gastroesophageal reflux symptoms not responding to medical treatment, and this will include antacids such as proton pump inhibitors, omeprazole, esomeprazole, etc., plus 2 other risk factors, which, no surprise, are the ones that put you at risk of having Barrett's. And this is being an ex or current smoker, white or Caucasian, age more than 50, male, family history of Barrett's, and obesity. Next slide, please. Right, so moving on, how do we diagnose Barrett's? Well, the traditional gold standard method is by examining the esophagus lining using a procedure called endoscopy. So during this procedure, a small tube that is the width of a small finger with a light and a camera at its end. It's inserted orally into the esophagus and stomach, and it can also be inserted through the nose as well. Sedation can be used to make the procedure comfortable. And what we do when we do an endoscopy is we particularly take a closer look at the point where the esophagus meets the stomach, the gastroesophageal junction, as you can see in the cartoon on the right, as this is the area of interest where the Barrett's develops. As already mentioned, instead of having a healthy whitish appearance, the lining has a salmon pink thickened appearance, and this is how we identify Barrett's and its extent. When the suspicious tissue is identified, biopsies, which are small tissue samples, are taken using certain tools that can be inserted through the endoscope. And these tissue samples can be looked at under the microscope in a laboratory by our pathologists. This allows us to confirm the diagnosis of Barrett's, but also look for any other cell abnormalities, which I will expand on shortly. Next slide, please. More recently, I should mention that there's an innovative new test known as the cytosponge or endosign, developed by the Fitzgerald lab. This has been definitively validated in large studies and is now rolled out nationally to identify and screen for Barrett's esophagus in people with persistent reflux symptoms. As you can see in the cartoon on the left, the cytosponge is a capsule on a string device. The patient swallows the small capsule, which is probably the size of a pill. This is attached to a string, and 7 minutes later, the capsule dissolves in the stomach due to the enzymes and the acid in the stomach, releasing a sponge that was previously contained inside the capsule. One of our nurses then gently pulls the string out, and on the way, the sponge collects cells from the lining of the esophagus for examination under the microscope again, to check for abnormal changes using a special stain called TFF3, which you can see in brown in the histopathology section on the right. Next slide, please. And if you click one more time, please. Perfect, thank you. So why is Barrett's diagnosis important? And I've already alluded to that. The reason being it's a potentially precancerous condition whereby a small number of people with Barrett's will develop esophageal cancer. And I would like to highlight that the majority will not. So overall, if I was to give you some ballpark figures, if we took 1,000 people with Barrett's, probably 3 to 6 out of those would develop esophageal cancer every year. That is less than 1% risk annually. But when you look at the cumulative risk, this confers a lifetime risk of probably between 7 to 13%, i.e. 7 to 13 people out of 100 with Barrett's in their lifetime might develop esophageal adenocarcinoma. However, once someone has a diagnosis of Barrett's, there are additional parameters that determine the risk of progression to esophageal cancer. And I think one of the questions asked previously was concerning that. And these parameters are incorporated in the monitoring algorithm that we use as clinicians. And these include, for example, the length of Barrett's segment, whether it's short, i.e. less than 3 centimeters, or long, more than 3 centimeters, a family history of esophageal cancer, again, smoking, again, being a male, especially more than the age of 50 and white, and again, obesity. But perhaps more importantly, as this slide alludes to, it's whether there are additional precancerous abnormalities in the altered cells of the Barrett's. And these precancerous abnormalities are known as dysplasia. And perhaps my pathologist colleagues will elaborate a bit more on dysplasia in the next presentation. But what I would like to say is that there are 2 different grades of dysplasia, low grade and high grade. And you can see how having a degree of dysplasia already increases the chances of cancer development. So in low-grade dysplasia, 0.5 to 13% per year, and in high-grade dysplasia, 5 to 20% per year. So high-grade dysplasia is thought to be the final step prior to cancer, which is why we want to treat that. And dysplasia itself is diagnosed by examining the biopsy samples that we take on endoscopy. Change of slide, please. So furthermore, why do we care about Barrett's? Another reason is that we have seen epidemiologically that the trends of esophageal adenocarcinoma, which is the esophageal cancer that Barrett can lead to, is a disease that is on the rise. This graph on the left shows you that although other cancers have slowed down in terms of their frequency relative to 50 years ago, esophageal adenocarcinoma continues to increase. Although I should highlight that the raw numbers compared to cancers like lung cancer are still quite low. Another thing to bear in mind is that the prognosis of esophageal cancer is quite poor once diagnosed at a very late stage, when treatments are known to be less effective, especially stage 3 and 4, as Rob has already alluded to. But the prognosis is extremely good if diagnosed at an early stage, especially stage 1. The projections on the right-hand side of this graph shows us that the numbers of esophageal adenocarcinoma are still expected to increase by almost 50% by 2040. So the risk of developing esophageal cancer and the rising trends of this sinister cancer is what has led to clinical guidelines recommending treatment and monitoring of Barrett's esophagus. Next slide, please. So treatment. That's important not just to alleviate symptoms, but also to reduce the risk of damage and progression to cancer. Lifestyle modifications are important and they have a role. This includes stopping smoking, losing weight, and then maintaining a healthy weight, eliminating foods and drinks that can trigger heartburn. For example, chocolate, coffee, alcohol, fatty foods, mint even. Stopping medications that can impair the sphincter, the gastroesophageal junction sphincter. Raising the head of your bed at night, avoiding large meals or having dinner too close to bedtime. So these are all lifestyle and dietary changes that you can make yourself to prevent further progression and alleviate symptoms. But the vast majority of patients with Barrett's esophagus are also treated with anti-reflux medications. And the cardinal ones are proton pump inhibitors that reduce the acid production from the stomach, things like omeprazole, lansoprazole, esomeprazole, pantoprazole. Change of slide, please. I will move to the endoscopic treatment shortly. These have been already mentioned, but in addition to treatment, we also monitor Barrett's by performing regular periodic endoscopic examinations with biopsies. And this is to ensure that the Barrett's itself has not progressed further and to look for any further abnormalities in the cells and for any early signs of cancer. And this approach to periodic checkup is called surveillance. As you can see on the left-hand side, we take multiple biopsies to increase the chance of picking up any changes of dysplasia that we know can be missed on single biopsies. And using this validated protocol, which is known as the Seattle protocol, we take random biopsies every 2 centimeters along the Barrett's length from each of the 4 quadrants, if you imagine the esophagus as a circle, as a tube, around the circumference. And furthermore, we have a very good look with magnification as part of our device and advanced imaging techniques, something like narrow band image, where we use lasers of different wavelengths to allow us to determine whether there are any subtle anomalies. And if we see any of those, as you can see, for example, a subtle anomaly on the right-hand side at the bottom right there, we take targeted biopsies from suspicious areas to maximize the yield of picking up anything precancerous. Next slide, please. So in these final few slides, I will take you through some more specific aspects of management and monitoring, and these depend on the extent, type, length of Barrett's, and the risk of progression to cancer, which is based on how abnormal the Barrett cells are. So let's assume that we have just carried out an endoscopy for a patient and we identify Barrett's. If there are no visible lesions, so if we can just click on the slide one more time, please. If there are no visible lesions, i.e. there are just flat changes of Barrett's in the lining of the esophagus, we take the biopsies, as I mentioned, with the Seattle protocol. We examine the specimen under the microscope. And if there are no changes of dysplasia, we monitor with periodic endoscopies, i.e. with surveillance. And if we just click one more time, please. And again, and again, and again. So no dysplasia. If the Barrett's is less than 3 centimeters in length, usual surveillance is endoscopy every 3 to 5 years, depending on other risk factors. No dysplasia, but with a length of Barrett's more than 3 centimeters, 2 to 3 years surveillance. There is also something called indefinite for dysplasia, which I will only touch on. That's where we're not entirely sure if there is dysplasia. It's a little bit equivocal. We suggest increasing the dose of the antiacid medications, and we repeat the endoscopy in 6 months to check again. So if we click again, please. Right.
Andreas, just 3 more minutes, if that's okay.
Yeah, I'm almost done. Thank you. So if there is low-grade dysplasia, which is considered the early stage of precancerous changes, we tend to repeat the endoscopy at 6 months. We verify the diagnosis with an expert second pathologist. And if this is confirmed, we need to treat by burning the abnormal cells off with a procedure called radiofrequency ablation. Where the risk is even higher, such as in the case of high-grade dysplasia, again, we treat with endoscopic therapy straight away, either with radiofrequency ablation or with endoscopic mucosal resection that removes the dysplastic Barrett's tissue. And the aim for endoscopic therapy is to remove or burn the unhealthy tissue and allow regeneration of the healthy tissue in that area. Next slide, please. So this is just a cartoon very briefly to depict how radiofrequency ablation is done. This is a device with a heat probe attached to the end of the endoscope. It allows burning of the abnormalities with the final outcome, as you can see at on the right-hand side. And then this allows regeneration. Right, and one last slide. This is in the case of visible lesions, i.e. not just the flat Barrett's, where we actually see something rising from the lining. We take targeted biopsies, as you would imagine. If these confirm very early cancer, as Rob mentioned, stage 1A or 1B or high-grade dysplasia, again, we use endoscopy to resect and remove the abnormalities. And the cartoon here just shows you how endoscopic mucosal resection is done. We inject solution under the lesion to lift it up, and then we use a hot snare or a laser knife to cut it out safely. There are, however, circumstances such as non-early cancers, for example, when surgery to remove the esophagus is the best approach, and Rob has already expanded on that. So I'm just going to conclude on the next slide, please. Barrett's esophagus is a precancerous condition whereby the healthy cells at the bottom of the gullet are replaced by abnormal cells. The risk of developing esophageal adenocarcinoma increases with the extent of abnormalities in the cells. Treatment with lifestyle modifications, medications, and endoscopic measures, and treatment and monitoring with periodic endoscopies depend on risk factors, length of Barrett's, and the grade of the dysplasia. So just remember that although the cancer risk is small, it's important for people with Barrett's to have regular checkups to check for these precancerous cells in order to prevent cancer or detect it at a stage where we can treat it effectively. So that's it from me. Thank you. The next slide is just a thank you slide. Apologies for any difficulties with the slides. I'm actually abroad at the moment, but I think
we really appreciate you joining, Andreas, and it was all very clear and very audible and great, getting lots of nice thumbs up. So very clear presentation. Thank you very much. We've got a few questions for you, Andreas, and I can join you in taking these. So I should have said at the beginning that we can't really give advice on individual cases, but we're happy to give some general pointers. So I've got two questions which are similar, one from Kerry Ann and one from Claire Thomas, about if one experiences regular symptoms of heartburn, and it may have been going on for some time, and may have a hiatus hernia and been on medication for a long time, how worried should that person be about complications of developing Barrett's and cancer, and what would you recommend in terms of getting checked out?
Yes, as I said, this is the cardinal red flag where we start thinking about investigating further about Barrett's having regular symptoms of reflux despite medical treatment. Although our guidelines suggest that we should have that plus a couple of other risk factors, if this is something that is ongoing and worries you, I would advise talking to your GP. And perhaps considering further investigation if this is something that has been going on for quite a while. I mean, we have guidelines, but as the name says, these are just guidelines that help to help us make decisions.
Thanks, Andreas. I mean, I would agree. I want to clarify the guidelines though, actually, because the guidelines are about the risk factors and history of reflux. The reflux doesn't have to be not responsive to treatment. If you have the risk factors plus a history of reflux, that's sufficient to be referred. And separate to that, if you have symptoms which are ongoing, which aren't responding to the treatment very well, even if you don't have any other risk factors, that's a criteria for referral, and that's all within the guidelines. So I would say to both of these questioners that if there's any concerns, get it checked out. There's endoscopy, and then increasingly we're able to, in many areas, depending where you live, able to offer cytosponge or endosign, so the capsule sponge techniques as part of the NHS implementation pilot. Although Andreas said it's been widespread without using these new tools through the NHS, they're still under kind of their early rollout, and so we're rolling out in some areas of the NHS, not throughout the whole NHS. It includes Scotland and Ireland, and we're still monitoring the results very carefully and auditing them to see whether this could then become completely routine. A question from David Moylan. Have you come across many patients in their 20s, and is their lifetime risk of developing cancer higher in that case? I think one problem, Andreas, you may want to comment on this, is that often patients, we don't know when the Barrett's has developed. So patients will only know about it when they've had their endoscopy, and that could be, just when they've been referred. So it could be in their 20s that they had their first endoscopy, or in their 50s or 60s. So it's difficult to know how long it's been there, isn't it?
Absolutely, absolutely. We don't tend to see many young patients coming for endoscopy, particularly to look for Barrett's, probably because the suspicion rate is relatively low in that population. But it is possible that Barrett's can develop at an earlier age, and we only pick it up much later because of that.
Yeah, and if we find it in young people, then of course we want to keep an eye on it, and the risk will depend not only on the age of presentation, but how long the segment of Barrett's is, and whether there are other factors like if there's a family history. So hard to give a precise, estimate of risk, but I think in younger patients we always take it seriously and like to keep a good eye on it. A question from someone called Sonia: any difference between NHS and private monitoring for Barrett's? Shouldn't be. You'd hope any endoscopist would do a good job. I'm afraid endoscopy surveillance is variable depending on the expertise of the individual, how much pressure there is on the endoscopy list, which might vary a bit, I suppose, between the sector, but increasingly the best practice is to have dedicated lists for Barrett's follow-up, so that the endoscopist has really got the time and the expertise to do a very thorough job. But it's not always It's not always perfect, but I'm sure people do their best. Andreas, do you want to say anything about that?
Yeah, so the only thing I was going to add is that in Adam Brooks, for example, once we know that one of our patients has Barrett's, we try to make sure as much as possible that they end up on surveillance list of endoscopies that have a particular interest in Barrett's or expertise in Barrett surveillance. I would imagine private and NHS otherwise would follow the same procedure of looking for Barrett's.
Yeah, should do. Thank you. A question from Lynn Brooks. Perhaps I'll take this one. How to explain if Barrett's is seen, inverted commas, by the consultant, however, the biopsy in the cytosponge do not show Barrett's? Well, to diagnose Barrett's, you have to both, if you're doing endoscopy, you have to both visualize it and have evidence in the biopsy that it is Barrett's and not just a normal stomach lining, because it can be difficult to tell when you just look at it, especially if it's a short segment, whether it's really true Barrett's or just a bit of an irregular join between the esophagus, junction between the esophagus and the stomach. So sometimes normal variations, biology doesn't always occur in straight lines, so it can be difficult to tell if there's just a little bit of an irregularity of where the stomach joins the esophagus or whether it's true Barrett's, but the biopsy confirms it, and we look for special features in the cells called intestinal metaplasia. Now with the cytosponge or the endosign device, obviously you don't look down, you don't have an image of the esophagus, so we rely on what we see in the cells, and we'll get back to hearing that in the next talk. So if both the biopsy didn't show the Barrett cells and the cytosponge didn't show the Barrett cells, then there aren't Barrett cells there. It's just when the endoscopist has a look, they thought there might be, but it's probably just a variation of normal. Not sure I explained that very well, but hope that makes sense. Good. And then a question from Lizzie James. I had a laparoscopic Nissen fundoplication in 2009. I've been treated with omeprazole for the last 5 to 6 years. Should I be asking for an endoscopy to check esophageal health? What do you think, Andreas?
I think if this has been going on for 5 to 6 years on medication and having previously had fundoplication as well, I would be checking this with an endoscopy.
Yeah.
Or at least I would be consulting my physician for an assessment.
No harm to have a discussion about it. Yes. Great. Well, thank you very much, Andreas, for joining us when you're abroad. Really, really appreciate it, and great talk. We'll let you go now, and I'm going to welcome Dr. Adam Duckworth, who's one of our pathologists. So Adam is a consultant histopathologist and cytopathologist, so he deals with biopsies and cell specimens. He practices at Adam Brooks Hospital in Cambridge, and he's also a reporting pathologist for the cytosponge and endosign devices. So thank you very much, Adam, for taking the time to join us this evening.
No problem. Thank you for inviting me. I'll share. I think it's easiest if I share my screen.
Yeah, should be. Thank you.
Bear with me a second. Almost there. All right. So hopefully.
Yep, that's worked. Thank you, Adam.
And you can see.
You might just want to put it onto full screen.
Just bear with me a second. So it should be at the start now.
Yes, perfect.
Yeah. Okay. Good. So I have been through and deleted a couple of slides just to avoid repetition. Is not a bad thing if you're not used to these terms. So that I'm aware that this is aimed some healthcare professionals and also patients. So I've tried to simplify it because sometimes the histology and pathology is a bit more tricky, and people use all of these terms, metaplasia, dysplasia, and I'll try and give you an understanding of what they mean. I'm not going to dwell on metaplasia, it's already been discussed, but we'll quickly touch on the anatomy. I'll show you how we get from the point, if you've had an endosign or a sponge test, how we get from the point of after the sponge is taken, what we do with it, and then what we see, and how that compares and contrasts with a biopsy specimen. So what we're looking for in these samples, I'll show you specifically each individual entity. So we'll focus on intestinal metaplasia, the different types of dysplasia, and then obviously adenocarcinoma, the end stage of that dysplasia carcinoma sequence that has been mentioned in the other talks. And then I think the main interesting point around all of this for us is where we find what we find difficult, the challenges with these cases, and the challenges, for example, with cytosponge cases as compared to biopsy specimens. So I'll stick with this. So let's just recap. We've got an esophagus or gullet lined by squamous epithelium, which is well adapted to the passage of a food bolus from the mouth to the stomach. Fine. Columnar epithelium in the stomach, and then the gastroesophageal junction. I've taken out some of the slides, so the endoscopy slide showing the Barrett's will follow shortly. But this is what we see on histology when we're looking at the gastroesophageal junction. So this is a section that's taken it's a longitudinal section. So the food would pass, this would be the luminal side. So this would be the tube of the esophagus, food would pass through. And this here is all squamous epithelium. So this is similar to the skin that essentially covers our body. So tend to have squamous epithelium lining the external surface. Is very good at dealing with things that could cause abrasion, but it's not particularly well adapted to the chemical injury that we've been discussing in terms of what we see with reflux disease. That's why we end up with the metaplasia. So we get injury to the squamous part, as has already been discussed. And then through a process that we don't fully understand, it gets replaced by the columnar epithelium. But columnar epithelium lines the rest of the gastrointestinal tract. So it looks morphologically different in different areas. So from stomach through to small bowel to large bowel. And then when we get to the anus again, we've got another squamo-columnar junction, and we're at the exterior again. So glandular and columnar epithelium very much internal gastroesophageal tract lining. Okay. And so you hopefully you'll be able to recall, if you've been paying attention, you've already seen this exact image. I noticed it, but this is just to emphasize. I'm about to move on to discussing the capsule sponge, cytosponge / endocyne. So the endoscopist gets to see the area of Barrett's. This has kind of just been answered in the question that was just asked. But so targeted biopsies can be taken, and then we get these small biopsies of tissue, which are representative of what the endoscopist has seen. So the biopsies are taken at endoscopy, and they're targeted. And so if a biopsy is taken of this area, we're expecting to see some form of metaplasia. And this is all the squamous epithelium. So this salmon pinky stuff is this metaplastic epithelium, which is eroded. This tongue-like extension has eroded and replaced this pale squamous epithelium. When we're dealing with the sponge samples, you swallow the capsule dissolves, sponge expands, and then hopefully, can you see my arrow? I forgot to ask, but hopefully you can see a green arrow here. I've made my arrow large specifically for events like this, but it makes it easy.
We can hardly see the arrow actually.
Oh, okay. Well, that's embarrassing. Well, anyway, okay. Well, so anyway, so the difference is this sponge expands, and then we pull it out back through the esophagus. So we're going to sample this area, and then we're also going to sample the squamous epithelium from the rest of the esophagus, and some of the material from the tonsillar area, and as it's pulled out of the mouth there as well. So it's going to pick up cells along the way. So We've got more extensive sampling, but we don't have the subepithelial, the connective tissue below that lining that lines the stomach and the esophagus. So the sponge is put in some kind of preservative and then sent to the lab. I'll show you what the lab do now. I'm going to show you this with images because they were very kindly sent by somebody from the lab. Hang on a second. Here we go. So the sponge in the preservative, then it's spun in a centrifuge, which separates out all of those cells from the rest of the fluid and basically makes them form a clump, so we can concentrate all of the cells together. And then we basically add together a fibrin clot to clot all those cells together, make them stick together into a clump. And then we embed, at that point, we embed them in a paraffin block because we need to take sections through these cells which are embedded in this material. So at that point, we embed them in a paraffin block, which is the same process as the biopsy specimens. Then you can see from the second image to the right, that's a microtome, which is how we cut histological sections. So very, very, very fine slices from this paraffin block. And then we stain it with an H&E stain, which is the same stain that's been used for decades. And then we've got the two, with the sponge samples, for most cases, we have a P53 and a TFF3 routinely that come with the H&E. Biopsies is usually just the H&E on its own. And so this is what we see. So there's a slide with a biopsy on, which you can see on the right here. And then on the left, you've got your fibrin clot, which has been embedded in paraffin, sliced, and then stained with H&E. And there's a scale at the bottom to give you an idea how large these slides are. But in general, that's the size of a slide, a normal slide, histology slide. With the sponge ones, they're then scanned, so we can look at them digitally. And we're in the trust as well, we're scanning all of our slides. So we've got digital images of slides, but we also use the glass as well, because a lot of us are used to seeing things on glass. And you get two very different you've got two different sampling techniques, and then you get these two different images in a sense. So with the biopsy on the right, well, actually, the sponge on the left, can anyone think what this material is here? Hopefully, even if the arrow is small, hopefully you can see it. So we've got strips of the columnar epithelium, so the sponge has pulled off this columnar epithelium, or the columnar lining, and it's also got picked up all of these squamous cells from the esophagus as it comes up, and then it's got this material here, and also this material here. So additionally to the columnar epithelium, we've got other sampling from elsewhere in the esophagus, essentially. So here we've got a biopsy specimen with we've got the lamina propria, which is the connective tissue which the glands are embedded in, and then we've got some submucosal tissue as well, actually, here. So you can see that we can assess the architecture of the glands on the right on the biopsy specimen, and we lose that in general on many of the sponge specimens. I have seen the sponges actually pull out microbiopsies of tissue where you can actually see lamina propria and the surface lining and the glands. But anyway, but the biopsy specimen in general, we know exactly where it's been taken from. It's a specific area, and we've got the connective tissue underneath, as well as the lining and all of these glands. And so this is actually tonsilate. This is the material that you'll see if you have a tonsillectomy specimen and we process it and section it. This is the stuff that hangs out in your tonsils at the back of your throat, in a sense, if you've still got tonsils. And this is some of the capsule material. And then, as I say, we pick up the squamous cells along the way, as well as the glandular epithelium. So what are we looking for? So we've already touched on this. We're looking for Barrett's esophagus specifically in the cytosponge specimens, what really helps us to determine if we think there's Barrett's esophagus is the presence of intestinal metaplasia. So metaplasia, we've already discussed, change of one type of tissue, one differentiated type of tissue to another. So you can have metaplasia from glandular to squamous in certain areas of the body, but here we've got the squamous lining of the esophagus, and this, the middle image, is Barrett's esophagus with gastric metaplasia, and this is called gastric metaplasia because this looks like the epithelium in the tissue that we see in the stomach. So we've got these long apical cytoplasm to the cells and quite small nuclei, and these cells contain mucin, which is basically to protect this layer and the subepithelial connective tissue from the acid in the stomach. And then hopefully you can spot the difference. With intestinal metaplasia, we see goblet cells. So these things here, these round things that look, they have a blue kind of hue to them. So on H&E staining, on routine staining, the same thing we've used for decades, in a biopsy specimen, in the majority of cases, if it's like this, we can say that that's intestinal metaplasia just by the morphology. We don't need additional stains. The TFF3 stain that was mentioned in Andreas' presentation helps us with the cytosponge specimens. I'll tell you why in a minute. But for the majority of biopsy cases, because we've got the architecture and more epithelium there, we can say, I can say that that's intestinal metaplasia. I don't need to prove that with any additional technique. So that's the difference. Presence of goblet cells, and it's called intestinal metaplasia because that looks like what we see in the intestine, and that looks like what we see in the stomach. So that explains those terms. Now, this is where we get into the tricky bit, which is, I would say I report specimens from the hepatobiliary tract, so the liver and the pancreas, and also the gastrointestinal tract. Dysplasia in Barrett's esophagus is one of the most difficult it's one of the most difficult areas, definitely, of GI pathology, I would say. It's something that most of us struggle with. It's something that we often show cases to each other, and it's something where you have intra and inter observer variability. So that means you can have variability in your opinion of what you think is something between that indefinite and low-grade dysplasia at a different time. So if you look at something a month later, you say, "Oh, this looks like low-grade dysplasia now. It was indefinite before." And then we can have different thresholds between different pathologists in the department, which is one of the reasons that we discuss cases and show each other cases. Say, "What do you think to this?" And just to emphasize how difficult this can be, we've got 3 images. And so the one on the left, you can see these are inflammatory cells. So we've got a basement membrane here and subepithelial connective tissue with these inflammatory cells in the tissue. These are the nuclei of the epithelium, so the glandular lining, and you can see here goblet cells actually. So there's intestinal metaplasia here. So under normal circumstances, in a completely negative normal columnar epithelium, the nuclei are basally located, and by that we mean at the bottom of the cell next to this basement membrane. And then we have we say apical cytoplasm, we have a lot of cytoplasm above that towards the lumen. And so sometimes with these sections, you saw how the fragments come out and the biopsies are taken. If the biopsy is sectioned obliquely, because we don't know exactly how it's going to sit in that paraffin wax block, we can sometimes get cross-cutting. So if you cross-cut slightly obliquely through this basement membrane, and there's only 1 or 2 nuclei there, if you looked obliquely, it can sometimes look like there's more nuclei in that area, but actually it's just cross-cutting. So you have to be wary of that and be aware of the fact that that can simulate this. You can see that there are some similarities. So each of these darker things here are a nucleus, and this looks more cellular. So here we've got inflammation again, inflammatory cells in the epithelium, And this looks very regenerative. They still look, the nuclei still look quite basally located, but there's certainly more suprabasal nuclei, and it looks more busy. It just looks more busy, if I can convince you of that. And then here we've got the nuclei no longer sitting next to the base. So they lose their basal polarity and they start to sort of migrate upwards, as well as becoming hyperchromatic and more closely compact, and so more cellular. So we've got here, this would be negative. This would be Barrett's esophagus with intestinal metaplasia, and these are reactive changes of cross-cutting. Then we've got here, this is low-grade dysplasia, and then this is indefinite for dysplasia. Now, when we say indefinite for dysplasia, we're not sure if it's low-grade dysplasia, because it's quite important. Once we say low-grade or high-grade dysplasia, then we're in that dysplasia carcinoma pathway that was mentioned in Rob's presentation. So we like to, if we're unsure, the indefinite for dysplasia category allows us to say, look, we're concerned, but we usually give a reason as to why we're indefinite. So if there's additional inflammation can cause reactive changes, and then there's this morphological overlap, this spectrum. So we've got this spectrum of changes where there's morphological overlap between these cells, and we're trying to put defined categories in that spectrum, and that's why sometimes we struggle. So not all cases are like this. I'm just showing you these are the basic principles, and that you're calling that low-grade dysplasia because of the increased cellularity, the elongation, the stratification there next to each other. It's not cross-cutting. They're longer than normal, and they've lost their basal polarity. We have one
Adam, just to make you aware, you might want to speed up a wee bit because you've got about 6 minutes left.
Okay, yeah. So I actually removed quite a few of the slides. So high-grade dysplasia is much more prominent atypia. You can see that there's far more nuclei, they're far darker, and there's far more variability between the nuclei. So that's high-grade dysplasia, which is much worse than low-grade dysplasia in terms of nuclear atypia. And then, as mentioned in the previous presentations, at some point, the high-grade dysplastic cells break through the basement membrane, and once you've got infiltration into the stroma below, then we're in the terms of esophageal cancer, otherwise known as adenocarcinoma. So that's adenocarcinoma. We've no longer got the epithelium lining the tissue just on the surface. Is also infiltration into the connective tissue below. So on a sponge sample, we see cases where we see atypia, and this is our category, similar category for indefinite for dysplasia. There are inflammatory cells in these, the inflammatory cells within these cells. They've still got a lot of cytoplasm. There's some variability. Not sure if they're dysplastic. So we can say atypia of uncertain significance. If you see that on a report, that's what we mean. We're not entirely sure. And hopefully you can see the difference between that and the high-grade dysplasia, where the nuclear cytoplasmic ratios are much higher. There's much more atypia in the nuclei, and we have membrane irregularities, and the chromatin looks very, very ugly. So that's the high-grade dysplasia. And then I was talking about the additional techniques that we can use. P53, tumor suppressor gene, is a protein that's present in the nucleus, and it essentially is in approximately 80% of cases of high-grade dysplasia will have overexpression of P53. So there's lots of this protein in the nucleus. It's telling you there's been lots of damage, and these cells have accumulated lots of essentially DNA damage, and the P53 is trying to respond to that. So P53 positivity can sometimes help us when we're in the indefinite for dysplasia category, so we can use that as an adjunct. And it can help us on the cytosponge cases, because if you have an atypia of uncertain significance kind of picture morphologically, but you have abnormal P53, then it's more significant, and you can sometimes say you're more suspicious for dysplasia. And as was mentioned in Andreas' presentation, the TFF3 positivity we use in cytosponge specimens. You can see these goblet cells, and they're positive with TFF3. And that is essentially used if we've only got limited sampling of something that we think is intestinal metaplasia. This can help identify it, because it just picks out these cells when it's less clearly obvious, and also it's easier to quantify when we can see TFF3 positive on the immunohistochemistry, and we can quantify on the cytosponge how many TFF3 positive groups, which roughly correlates to the length of the Barrett's and the risk of dysplasia. So I've already touched on the challenges in intestinal metaplasia in the sponge samples, the differentiating between inflammatory atypia, the indefinite for dysplasia category, and low and high grade dysplasia, which is atypia of uncertain significance in sponge samples. Hopefully you understand how we use P53 and TFF3, and that we rely on our colleagues an awful lot, actually, to help determine which is the most appropriate category to put these cases in. So that's the summary. Definition of terms. I hope that made sense. I hope it was clear enough. And I'd just like to acknowledge that some of the slides were from my colleague, Dr. Maria O'Donovan, and Alex Bowman, who took the images from the laboratory. So
thank you, Adam. I'm sorry to speed you up because you suddenly got very close. You were closer to the end than I realised, but that was all very clear. And I think we're very glad that there are people like you evaluating these really complicated and difficult, in some cases, to interpret specimens. And we all take our hat off to pathologists, I think, who often go underappreciated and unrecognised for all the hard work. And there are lots of people agreeing with me.
You noticed there weren't any photos of the pathologists in Rob's presentation, but that's because we don't like to be photographed. So that's fine. We sit in our office, we close the door, and we just we do
work
the
away.
Yeah, sorry, I got carried away on the. I got so immersed in it. So I probably could have spent half an hour. Could have gone by. I was talking about dysplasia and.
That's fantastic. Your passion came through. So okay. I guess think in the future. I get a bit of a controversial question, but to what extent, is pathology going to become old hat one day, and it's all going to be molecules and sequencing that's going to spit out an answer for us, or is it going to be a combination? What do you think?
I think it's going to be a combination. This is really difficult to predict. We've got AI coming into pathology, so we've got AI supporting us in particularly in these cases. It begins with counting things. Then we've got the molecular stuff, but I think it'd be a few years. I think 10 to 20 years. I think I'll probably be retiring to the Polish countryside when when we're no longer required. But hopefully we can apply our skill set somewhere else. I don't know.
Well, I think although AI is very useful adjunct, I think we shouldn't underappreciate that context and nuance that the pathologist brings from a wealth of experience. So I suspect it'll be a combination.
I think so,
yeah. So brilliant. Thank you very, very much, Adam, for really great talk.
Thank you.
And so I'm going to move on to our last talk from Claire Lamb. So Claire is a dietitian who works at Addenbrooke's. She graduated from Nottingham with a master's degree in human nutrition and dietetics, and she's been working in Addenbrooke's for nearly 10 years now, and she specializes in upper GI in particular. And so she's going to try and tell us about what are the dietary tips to reduce heartburn.
Right, thank you, Rebecca. I'll just see if I can also share my screen. I'm sorry, it's not giving me the option of sharing the slides.
Adam, can you help? Is that okay?
Is that us? Can you see it now?
Yes.
Yes, you might just want to put it onto full screen.
Yeah.
It should be. Is it on full screen now?
Not yet.
I've got your slides. I can share them if you like, and I can click through them.
Yeah, that might be helpful because it's
Thanks, Adam.
Thank you. Perfect. So yeah, so I'm Claire, one of the upper GI dietitians. So I think my talk's slightly different to some of them that you've heard so far. And I'm conscious that I can give you our kind of evidence and tips and advice for reducing the heartburn and reflux. But as a lot of you are probably living with a lot of these symptoms, I'm aware that there are probably things that you've maybe thought of or that work for you, that this might be a great forum to share those as well. There's quite a lot of anecdotal evidence around what works for heartburn and reflux. So I've focused on the things that there are some papers published on and a little bit more evidence for. So if you go to the next slide, please. So a lot of this has been touched on the talks so far, but I just wanted to briefly outline a few of the definitions of things. So acid reflux is that kind of actual upward movement of all the stomach contents towards the throat and the mouth. And then the heartburn is kind of that unpleasant burning sensation that you'll feel behind the breastbone that's due to that upward movement of those stomach contents. And then we kind of overarch all of those things with gastroesophageal reflux disease, which is when those things cause quite troublesome symptoms or complications. So as we've obviously alluded to, some of those things can lead to the Barrett's. So on the next slide, again, a lot of this has been outlined already today, but some of the symptoms that can be caused by the heartburn, the reflux. So that heartburn, that chest pain. A lot of patients also describe a cough or hoarse voice, and that can be due to some of that damage that's caused by that acid reflux. Throat pain, which I know we've even already had a question about that actually sometimes requires pain relief to try and help to manage. Globus as well, and that's just a fancy name for feeling like there's a lump there all the time, and that can be either when you're eating and drinking or actually just constantly in the background. And that non-burning chest pain, so burning chest pain might be more used to describe kind of heart attack type symptoms, whereas that just kind of chronic pain that's there all the time. So these are some of the longer term consequences, and actually things that I would, as we've already said today, suggest getting checked out. So if these are things that are going on for quite some time, making sure you've got some input. So the next slide. So these are like what I said before. So these are just some of the foods that I've focused on. And that's because there is a little bit more evidence around these foods. There are obviously lots more anecdotal foods, and I'm sure you find things that do or don't work for you as individuals. So really that reflux, as I think everyone has mentioned already, normally the movement of food and air between the throat and the stomach is regulated by a muscle barrier, so that a valve. This temporarily relaxes as we swallow, and then in theory it's supposed to close back over after we've swallowed to stop things refluxing back up. So the exact causes of some of this reflux disease are a little bit unknown, but it's thought to be that obviously that muscle, if it's slightly weaker or not working as effectively, then there's more opportunity for things to come back up. So that can be used to explain why some of these foods might cause an increase in the reflux. So if we look at the top one first, so the calorie dense meals. So there's a lot of evidence to suggest that kind of overall calories in just one sitting, so kind of a rich meal or a dense meal, can cause an increase in the reflux. There's some suggestion that this might actually be related to the fat in the food. So having high fat foods can cause a release of some hormones, and those hormones actually relax a lot of the muscles in the body. So that could be relaxing that sphincter muscle. So in terms of advice for this, we think about trying to spread your kind of calorie intake or your energy intake across the whole day rather than in one big sitting. So thinking about drinks then, so including the kind of the drinks and alcohol. So fizzy drinks and citrus drinks have both been shown to increase that reflux, and that's again because of that pressure they can create, so they can open that valve. Alcohol as well, so the alcohol we think is more related to, alcohol is a muscle relaxant, so that could be relaxing that muscle and again giving that more opportunity for that stomach acid to come back up. There's also been some more evidence to suggest that beer and wine actually increase stomach acid production, whereas things like spirits don't. So it may be that actually drinking spirits is more helpful, whereas the beer and wine can cause more relaxing effects, or can produce less of that stomach acid. So spicy foods, so there's actually a bit of variable evidence with the spicy food. So there's some thoughts that actually spicy meals tend to be a little bit more energy dense. So it could be that again they're rich energy dense meals that are causing that reflux from the things that I mentioned before. Or it could be that in spice you tend to find something called capsicum, and that can increase the speed of digestion, which can increase a rapid production of stomach acid and enzymes, and that can create that reflux because there's quite a lot of stomach acid in there at once. I wanted to include fiber here because there's actually been some more emerging evidence that some of the studies that they have done suggest that those who've got reflux disease have got habitually lower intakes of fiber generally. So it averages about 6 grams a day in one of the studies that was published in 2018. And then actually by increasing fiber in the diet, it can reduce reflux disease. So that was done in some patients, it was done through diet, so selecting foods that were higher in fiber. And in other patients, it was actually done with fiber sachets, and both of which produced really positive results in terms of reducing that reflux disease. Again, the exact action of that is slightly unknown. So caffeine's another one, but interestingly, both caffeinated and decaffeinated coffee are seen to exacerbate the symptoms, whereas caffeinated and decaffeinated tea don't seem to have any effect. So actually we're talking more now about the fact that it may be something that's actually in the coffee itself, rather than the caffeine. So it is worth suggesting trialing something that's not coffee. So rather than focusing on the caffeine, could you actually just change your hot drinks to something completely different away from coffee? And again, as I've mentioned a few times, there are different things that work for different people. So what I often explain or discuss with patients in clinic is actually keeping a bit of a food and symptom diary. So kind of writing what you might eat or drink in a day, and then when you get the symptoms. So the symptoms might include things like the taste in your mouth, the pain, even the coughing, which some people find particularly can happen overnight. So it's still worth writing those things down. And as I'll go on to discuss in the next slide, it's also worth writing down the times of the meals as well, and maybe when you have larger portions. So if you can go to the next slide, please. So as well as particular meals, we talk a little bit around eating habits. So one thing that can be really helpful is eating smaller, more balanced meals. So that relates a little bit to that kind of high density calorie meal that I was talking about, just spreading that across the day, but also the volume of the meal itself. So the more food that you eat, obviously, the more stomach acid is produced, so the more chance there is of that coming back up. So eating smaller, more balanced meals throughout the day has a big impact on reflux. Trying not to miss meals. So sometimes actually that reflux can be caused because there isn't anything in the stomach for that stomach acid to work on. So making sure there is something in there all the time for that to work. So kind of we say every 2 or 3 hours, making sure you're having something. And that could be a nourishing drink as well, so it doesn't have to be food. Avoid eating really late at night, and then having your evening meal kind of 3 to 4 hours before going to bed. So again, that's kind of just making sure that when you're in bed, you tend to lie flat. And even if we recommend sleeping propped up in pillows, I know most people find you tend to slide down anyway. So you still tend to wake up in the night and you're much flatter than when you started. And that can just increase that that reflux, because obviously gravity is not helping as much. So avoid eating on the go, try and relax at meal times, so just giving it that time to digest. So sitting down after meals can be really helpful, but also sitting up when eating, so not kind of sitting down slumped in your chair or hunched over kind of a lap tray. Again, and that's just a lot of gravity just helping you out there and playing its part in that side of things. There's also, obviously it doesn't quite fit into the diet side of things, but trying to reduce stress as well, that can be really helpful. So just taking that time out to have those meals. And if we go to the next slide, please. So yeah, so that bending, lifting or lying down. So again, that's just encouraging that the acid to come forward. So work with gravity. Also wearing loose clothing. So if you've got things that are really tight and you're creating a lot of that pressure, so this includes things like belts, generally tight tops. So just having a think about whether you're quite uncomfortable generally, just loosening things off, giving the space for that food and drink to pass through. As was briefly mentioned by Andreas, I think, so aiming to maintain a healthy weight and reduce your weight if you're overweight. So we know that obesity is a big risk factor for reflux. I haven't gone into too much detail here about obviously maintaining healthy weight and things. It is something you can approach your GP about. Also, the NHS website has got some really great resources that are all backed by dietitians to help support weight loss as well. Smoking is another risk factor. As I mentioned before, alcohol can cause reflux, but maybe choosing spirits over the beer and wine can be helpful, but generally alcohol is still a risk factor. Sleeping in that semi-upright position, so making sure you've got a couple of pillows. Sometimes it's helpful to put pillows under your knees as well, so to really help stop sliding down, or to make sure you've got an end of your bed, so whether it can be pushed up against a wall, so that if you do slide down, there is something stopping you. And like I said, so just making time to relax. Stress can contribute to reflux, so take that time if you've got it. Chatting to people if there are other stresses in your life as well to try and help minimize that. So that's kind of most of the things that there is a good evidence base for. So my talk is quite short, but I thought it might be helpful if we talk through anything that is working for other people. But if we go on to the next slide, I've just kind of mentioned briefly where you can find some more information. So obviously the Heartburn Cancer UK website is great. They've got a really great page on kind of diet and lifestyle tips. There's also a great page on the British Dietetic Association. So if you go onto their website and type the words reflux, they've got some great advice, and actually they've got all the references in there as well. So if you wanted to, you can go off and read a little bit more information. And also talking to your local dietitian. So we've got obviously quite a big team here at Addenbrooke's, but community dietitians even should be aware of a lot of this advice and tips. So that can be helpful. I have listed the references on the next slide, but I don't expect you to look for them all. But most of the references I've used are on that British Dietetic Association website. So if you do want to go on and read anything else, that's where you can find the most information.
Brilliant, Claire.
And
That's
thank you.
Really fantastic. Really, really full of practical tips, which I think is exactly what was needed, and really clear explanation. And I learnt quite a few things from your talk. So brilliant. So there's a question for you about gluten intolerance.
Yes.
And acid reflux.
So I would say no, essentially. So they're two really quite separate problems. It can be quite difficult, I think, if you've been suffering with reflux for quite a while, and you maybe haven't been able to get on top of it. It's not unusual to try and start to think of other things. So, could it be IBS? Could it be celiac? Could it be something else? Essentially, the two don't go hand in hand. There's no reason to say you've got reflux. You could also have celiac, but they're not necessarily related. So I would say always visit your GP. They can do all the necessary tests. There's lots of other things and signs for gluten intolerance, so that's something they can test for. If you're starting to think that, I think the most helpful thing is to keep one of those food and symptom diaries that I recommended, and you can start to see if there are any links to any foods and things. But it's always, with these kind of things, I'd say it's always sensible to not have to exclude it if you don't need to. So keep the food diary, because I wouldn't want you to cut out anything you didn't need to.
Thank you, really helpful. And there's a similar question that I'll take about whether there's a connection between pyloric stenosis in babies and getting Barrett's later in life. And again, as far as I know, these are completely separate conditions. The pyloric stenosis has to be fixed fairly promptly for babies as it makes them vomit. So that should sort it out. And so it shouldn't predispose to reflux as long as it was sorted. So I think we've had a terrific evening of 4 very engaging, detailed talks. I'd like to thank all the speakers very, very much indeed.